So let's go. Hi there. Good morning from Brazil. Here we are in the morning, and I'd like to welcome you all in this presentation of my course regarding the treatment planning and the refinement in orthodontics. This is a class that I give just since the beginning, trying to focus on the biomechanics. But before that, for you to understand what's going on, how I see things, I'm going to focus first of all in the diagnosis. Why is this? Because diagnosis, it has everything to do with treatment planning and everything to do with biomechanics. I'm going to show you, I'm going to prove to you that there are some aspects of the facial and smile diagnosis that are directly related to the biomechanics and to the finishing and to the refinement in orthodontics. So my name is Kleber Meirelles. As you probably know, I'm an orthodontist here in Brazil. I'm an international speaker, and I've been teaching this for a long time now. And I'm very, very confident that you are going to profit a lot of this kind of class, because this is something that you need and you are going to use directly in your daily practice. So let's move on to our presentation. And before I even start showing to you step by step how I do my treatment planning based on the face-driven treatment planning, I'm going to show you one case that shows the importance. In my mind, it's very clear that this shows the importance of understanding the concepts and the nuances of the facial analysis. In this case here, as you can see, it looks like a beautiful guy. This is Pedro. He's one of my patients, and he just finished treatment like one month ago or something like that. And Pedro came to me with the chief complaint of just wanting to use Invisalign or aligners to treat the malocclusion. And of course you are going to see this, we have the opportunity, we have the possibility of treating him this way, with the aligners, with the Invisalign, or whatever aligner you want. But let's understand a little bit more about Pedro's face and the occlusion. And if I chose to use Invisalign in his case, I would probably miss one great opportunity of giving him a little bit more of volume, a little bit more of lower anterior face height. And this is something that we have the opportunity to do now, and you're going to see how important it is, especially when you think about the time. With time, he's going to have less aging features in his face, because we are now providing a little bit more of lower anterior face height for him. And here it is, he's a facial patient with a symmetric positioning of mandible on both sides and a good commissure, labial commissure without asymmetry. Moving on, we see that we have here a little bit of a problem. We have the lower third of the face. We know that this lower third, it may be a little bit greater, larger than the other thirds. In Pedro's case, we see that he has this lower anterior face height decreased. And when we see the thirds of the lower third, meaning upper lip and lower lip to menton, to the mental position, we see that we have a short lip. And I'm going to show to you here in this class how I see this. Mostly related to ratio and substitution to numbers. I really don't like absolute numbers for doing this kind of measurement, for doing this kind of evaluation. And I rely on the ratio for that. So relying on this feature here, I see that he has this short upper lip. This is something that I will put in my my chart of problems, and then I'm going to establish the solution for this problem. So first thing here is this. Since his mother is a dentist, she was an ex-student of our course, she understood that I needed to do this kind of thorough evaluation, even though he just wanted to go with aligners to treat this little bit of this lateral incisor displacement. But Pedro, let's see how it goes when we see the whole picture. And here we go. We see that he has this centered upper and lower midlines. we go with this evaluation here. Both upper and lower midlines are centered in relation to the upper face, the mid face, and the lower face. So this is good for me. And I'm moving on in my diagnosis. I see that he has this symmetric positioning of the canines, which is very good because we don't have a subdivision malocclusion in his case. And moving on, we go to other features of the face, other traits. For example, here we have a good feeling of the buccal corridors. We don't have a cant in the arch, which was expected to have if he had an asymmetry, not the case. Moving on, now we go to the profile analysis, and we see a problem here. The rotation of the mandible. Let's move on, and you're gonna understand how I see things in this condition and how my treatment planning was based on this situation here. Pedro has this lower anterior face height decreased, as you know, and now we see the profile, facial profile angle, a good facial profile angle that puts him almost in a class 3 condition because of the rotation of the mandible, the counterclockwise rotation of the mandible, to be clear. And we move on in this analysis. We see here his face, the position of the maxilla in relation to the face, good position of the maxilla. We have also a good little bit acute or closed angle, nasolabial angle, but for me it's good. I like this angle. Most of people nowadays, especially nowadays, prefer this kind of lip feeling. So I don't consider this a problem. We go here to this relationship, to the ratio between the total lower anterior face height, considering the total anterior face height from the glabella to the menton, and the lower anterior face height from the subnasale to the menton. And we see that we have a decreased lower anterior face height. We are going to focus this a little bit further. In this case, you see that the upper lip, which was in a good situation, in a balanced situation, would have 1/3 of the lower third. This upper lip is shorter in relation to the total amount of the lower anterior face height. So we see that we have the total as I told you before, I don't rely on millimeters for that. I'm just using here the numbers, the dots that we see in PowerPoint or in Keynote. We can measure this. Since this is a ratio, we don't need a ratio. We don't need to use the millimeters, okay? So we are using the relationship between upper and lower. In this case, he has this short upper lip, which is in our mind already, and we are going to consider this for the treatment planning. Moving on, we see a good maxilla and position, a sagittal maxillary and mandibular positioning, and we have this submental cervical angle a little bit. I like it, I kind of like it, but he has this kind of fat here and this portion, which is from his feature. And we see this mandibular sulcus contour, good, not bad for him. It should be worse. And here we have the position of upper and lower lip. It's very important for me because I prefer more full lips, especially in a kid like him, in a growing kid like him. So he is gonna grow up, and with this lip, it's gonna resemble aging very, very early in his face because he doesn't have this lip feeling that we like, that people like. And with time, we know that this kind of thing decreases. It won't increase. So now it's up to us to move to change this. So in this case here, I plan for doing the proclination of both upper and lower lip. And here we have the position of the pogonium in relation to the lips. I kind of use this differently from here. I'm going to show it to you a little bit further, but let's move on. Here we have it. We have a good positioning of the pogonium, the soft pogonium, in relation to the lower lip, which is good, which people think is a very beautiful feature from the profile analysis. And moving on, we see the problems are located in that position. And this is one other feature and one other evaluation that I like to use in such cases, especially in such cases with lower anterior face height, because we know how much we can change that. And if we want to use millimeters, we can even see in how many millimeters we can use during the extrusion of upper anterior and lower anterior teeth for being in a good position. This is from an article from two Brazilian researchers, Carlos Alexandre Câmara and Renato Martins, who posted that the most important thing here and the relation of the upper lip to the tip of the upper incisors is something like 2 to 4 millimeters. So we see that it's almost contacting this. So in a rest position, we can go downwards with the upper incisors, which is going to be good for him. Since I want to increase his lower anterior face height, this is something that I consider positive in my analysis. So let's move on. Going on with the cephalometric analysis, of course, I'm not using all those factors here, just those who are going to affect my treatment planning. And we have the positioning, the inclination of upper and lower anterior teeth. We have a little bit of proclination of upper, and here one analysis that I really like very much in such condition, which is McNamara triangle. We see here that we consider that Pedro's sagittal positioning of the maxilla was good. Do you remember that? So being good, I'm starting from this point. 90 millimeters is the number that we have in Pedro's face. The CO, the condylium to point A, it has 90 millimeters. Considering this a good positioning of the maxilla, I'm starting at this point. What would be a good size of the mandible and the lower anterior face height for that maxilla that I considered good? For the mandible, it would be 113 to 116, and he is around this, 114. And here's the problem. You see, just consolidating what we saw before, we have here the good number, let's say the good proportion for that size of the maxilla and the mandible would be 63 to 64 millimeters. And Pedro, he's just 57 millimeters. So he's approximately 6 to 7 millimeters short in lower anterior face height, if we want to use this kind of absolute number. But again, this is something that we are consolidating data by data, topic by topic, feature by feature. So we are just summing everything up so we know in the end what the problems are. So we see here that the proportion is not good between upper and lower lip. The lower anterior face height is not good in relation to the other thirds. And we are adding now information so we can have in the end the whole picture to show Pedro and to show his mother. So let's move on. We have it here, the occlusion. Beautiful occlusion, a class 1 with proclination of upper anterior because of the curve of Spee and the contact that he had between upper and lower anterior teeth. So we knew that this was going to happen. We knew that this is, before even looking at the occlusion, I already knew that he was a class 1, probably a class 1. Difficulty here is to understand what to do. Because if we go just thinking about what our patient wants and we deliver what they want and we don't give them the whole picture, the whole set of information so they can decide, we are hiding some important information from them. So we need to do this. And now I have the opportunity to give Pedro and his mother more options. What are the options here? I'd like to increase his lower anterior face height. And I have a protocol for that I'm going to show to you right now. Okay, so we have here the occlusion and the occlusal view of upper and lower teeth. And here we see the magnitude of the curve of Spee. We have a deep curve of Spee. We measure the curve of Spee from second molar to the incisor, and the deepest part of the curve is what we measure, okay? We have the panoramic X-ray, everything is all right, as expected, no problem. And we go on with the treatment planning, and we wanted to do something for him. Increase his lower anterior face height without correction, sagittal correction or anything, but changing a little bit of inclination of upper and lower incisors. But mostly what I wanted to do was this. I want to do the correction of the curve of Spee by means of extrusion of posterior teeth, intrusion of anterior teeth, and rotation of the mandible down and backwards a little bit more, because I wanted and I accepted to do this lower anterior face height increase. So in this case here, what I'm doing the extrusion of posterior by means of using this cantilever here. I'm using cantilevers in both sides so I can have the intrusion of anterior, extrusion of posterior, and you can see here, I'm not using a three-piece arch approach for him because I want to do a little bit of proclination, no problem in this case. So I wanted to do the extrusion of posterior, and here the cantilever will accelerate it. The cantilever will rotate the mandible, the molar, I'm sorry, going mesial up and distal down. What is going to help to level the curve of Spee, because we're having now an upward force in the mesial of the molar and a downward force in the distal of the first molar. Everything that we want. Also, we have the intrusion and the intrusive force distal to the canine. I can apply mesial or distal to the canine. In this case here, from the beginning, I just didn't want to go in proclining lower anterior teeth since the beginning. I want to do that in a more controllable way using rectangular wire for that. So I use the force here distal to the canine bracket. I could use, again, mesial, as you can see. In another point, at other point of our treatment, I changed the point of application, going a little bit further, mesial now in relation to the canine bracket. So we have now the intrusion being made. And what is the thing here? In this case, what's the protocol that I told you before that I'm using? I don't bone the second upper molar. Since I'm just leveling the lower curve of Spee, what I'm doing here is placing in the first upper molar, I'm placing a bite ramp, resin in the occlusal aspect of the upper molar, so I leave free the second molar to extrude. Do you remember the scissors? So when we do this, when we increase the posterior volume, the posterior contact, we are gonna increase the lower anterior face height in a relationship, in a ratio to 1 to 3. For each 1 millimeter that I grow here, that I increase here, I increase lower anterior face height in 3 millimeters. Some people say 4, but 3 millimeters, let's say. And what I'm having here, I'm leaving the second molar free to extrude. And after extruding, then I go doing the trimming, I'm wearing the resin, the bite ramp, so I have the extrusion of anterior, but establishing the posterior contact, I'm keeping the lower anterior face height increased. So do you understand? What I'm gonna do here is increase the lower anterior face height by means of free extrusion of the upper second molar and also a little bit of extrusion of the lower first molar. Sometimes we don't have it. Yes, we don't have it because the force we're applying here is not that much, and we can have this occlusal contact, hindering occlusal contact, avoiding the extrusion of lower first molar. But with bite ramps, it's more common to have the extrusion. So in this case, I'm doing the bite ramps also for this. And we see here, we have the complete correction in less than 1 year and very fast because we did since the beginning the correction of the curve of Spee. As you can see here, before doing the intrusion, before the intrusion arch being applied, and after the intrusion arch, we have the leveling of the curve of Spee with a little bit of proclination and a little bit of inclination, both proclination, body movement, and inclination of lower incisors. And you see here, before and after, we have the correction of the curve in the upper arch also. And when we compare before and after, we see that we have the complete correction with a little bit of proclination, which is completely expected and is very fast. And is very fast because we applied the right concept since the beginning, you know? So it's not about just about the mechanics itself. The biomechanics here is like a slave from the treatment planning, the diagnosis itself. In this case, what we see, a fast correction because we based all the treatment planning in our analysis of the face, facial analysis, the analysis of the occlusion, and the analysis of the inclination and the cephalometric analysis and everything. So in this case, before even starting the treatment, I knew everything was gonna happen during the treatment because the focus here, even though we are thinking about the refinement of the occlusion, we start the refinement here since the beginning. Otherwise, we are just treating our patient and we are treating without completely knowing what we want, you know? So this is a good example for me how the treatment planning is important, how the facial analysis is very, very important and needs to drive our attention and to drive everything in our treatment planning. Here we have before and after. We don't see much of change, but let's move on to what happened to his face because it has to have something different. Just otherwise, we just use aligners and it's okay. But look at this. We have Pedro before and during treatment and at the end of the treatment after removing the appliance. What we see here, we see a lower anterior face height increased. And look how important it is for his face. Yes, it's something very soft, it's a detail, but it makes all the difference. Here we have the reference that we use before and after treatment. So as you can see, we have more lips, protruded lips. We have lower anterior face height, more balanced in relation to the total face height and everything. So let's move on. Look at this. Look at this beautiful smile before and after. And we see that we have before and after this condition here. Look at the upper lip and you see that we have an increase in the upper lip, which makes all the difference. With time, guys, with time, it will make more and more difference for his face. So what we did here was the treatment planning, face-driven treatment planning. And now we have a beautiful position of upper and lower lips in the frontal view, in the profile view, and everything. And we see that with time, Pedro is gonna be favored because of this kind of treatment, okay? This kind of treatment. So just for you to see, to understand the importance of knowing what we are doing in biomechanics, but before biomechanics, knowing what we are doing regarding the treatment planning and the diagnosis. Facial analysis, very, very important. 3 points of treatment, before treatment, after doing the leveling of the curve of SPIE. I like to have this cephalometric X-ray to compare and to see if I can go or not further. And we have the final cephalometric X-ray here. And here, before and after treatment, and what we gained, what we gave him during our treatment. See, I hope you agree with me. The most important thing here is not thinking about just biomechanics. Biomechanics is the slave to the treatment planning and to the diagnosis. And it goes in relation to them. We don't apply the biomechanics. We don't choose the appliance before understanding the problem. This is wrong. This is something that we are not favoring our patient when we do that. We are just applying one medicine to all diseases. It's wrong. We need to apply the right medicine depending on the disease. For knowing the disease, I know that I have to run the sequence of the diagnosis and the analysis and everything, okay? So this is the most important thing for us. And here for just finishing the cephalometric X-ray that we need to control during our treatment, the panoramic X-ray, I'm sorry. And here we have our topics on facial analysis. So I'm gonna go now step by step. Of course, I'm choosing here the topics that I consider most important for you. Of course, we don't have time to go with a whole set of facial analysis, because it's too long and sometimes not that important. Of course, you need to understand everything. Of course, you need to seek more information about it. But in this case here, I'm going to focus on those informations that are going to change my treatment planning and pay a huge hole on my decisions, okay? So we know that with time, depending on the local that we are using, we are working. Some places we have more things related to the lips. In some places people like thin lips. Other places people would prefer thick lips or more or less protrusion of upper incisors, lower incisors. It depends. And depends on the local, depends on the time, depends on aging and everything. So we need to understand everything before we apply in our patient. The beautiful face is sometimes related to some subjective aspects. But here we need to focus on objective aspects. But for having everything together, the subjective and the objective aspects, I prefer to use, rather than millimeters, rather than numbers, I prefer to use ratio for that. And this is important for me because I see many things one in relation to another. Facial analysis. The facial analysis, far the most important thing in my treatment planning decision. The importance of facial analysis is related on determination of the diagnosis, identification of the problems, a face-oriented planning, treatment planning, and to communicate with our patient what we want to do, what we are gonna do. And so they can understand and they are part of the treatment together with us. So we need to focus on the aspects that are different from what our patient want and what we ourselves want. And we are based on science for that. We know scientifically speaking that we have the standards, and of course, this is one point from which we are going to start, but we are not focusing on this absolute image of the beauty because the beauty is more subjective than that. Facial analysis, we're going to go facial frontal, profile analysis, and step-by-step understanding the most important, for me at least, most important topics that I use in my diagnosis. First of all, we need to put the face of our patient in a horizontal position, so we can use different analysis for that or different points for that, the canthal or the pupil, we can use both. And even using them, sometimes we have a little bit of difference in height of the pupil and everything, but this is the most reliable, in my opinion, way to do this. Put in the intercanthal plane for positioning the face horizontal in relation to the floor. The natural position of the head, well, we have some different ways to doing this, like use mirrors for doing that. We can use the position of the camper plane and everything. So here in the frontal view, this is one important aspect, one important reference for doing this, okay? And we do, from now, the facial type is important because we choose specific treatment plans regarding the facial type. We have here the good relationship between the horizontal and the vertical aspect of the face, and it puts her in a mesiofacial profile, facial type. And facial types are important. Yes, they are. But sometimes you have different from the mesiofacial type, like dolichofacial type, and even a dolichofacial type can be beautiful. If it is balanced, it is beautiful. It's not something bad to do, something bad to have. So we just need to focus on the problems, not the facial type itself, because it's genetic. Okay, and I'm not changing it. I don't prefer a facial type in relation to another. I just see and analyze, and I understand that specific facial types may have different malocclusions, but facial types are not problems. They are types, just that. We have here a dolichofacial type, meaning in this case, for example, let's say relating to the treatment. If I wanted to do the advancement of the mandible of such a patient like this, Mandibular advancement in dolichofacial type in vertical in patients, they are not very good, and they don't favor the face most of the time, because we increase the lower anterior face height, which in those patients sometimes are already increased. So we pay attention to that. Horizontal is different. So if I had a horizontal patient with a hypodivergent patient using a cephalometric terminology, I will do the advancement of the mandible, increasing the lower anterior face height, which in that kind of face height is good. So it's completely different. In this case here, we have a dolichofacial type, and we also assess the symmetry or asymmetry. Great asymmetries need to be focused, but slight asymmetries, they are very common, and they're related to the volume and everything, so we don't pay attention to that. We just see that, and if this is something that our patients are not considering something bad for their faces, we just say, we just put in our paper and we move on. Look, for example, here, we have this beautiful lady with this asymmetric volume on the face, and when we just do the mirroring of her center face, we see three different types. We see three different faces. We see her own face here and different volumes changing the aspect of the face itself. But when we see this picture here, we consider this a good symmetry of the face. Another thing, the balance of the facial thirds. Another thing that is important and is different in different facial types. We have here the facial third from the trachea to the glabella, from the glabella to the subnasale, and from the subnasale to the menton. We have the thirds of the face, but the lower third of the face is usually a little bit larger than the other thirds, than the medium and the upper third. And we see that this is not something bad. We see here from Epker that he found that the lower third of the face is larger in relation to the other faces in normal facial types. So we expect that to happen. It's not wrong. It's not absolute. Upper, middle, and lower thirds completely symmetric. They are not. And we have other possibilities of seeing that. For example, here, the lower lip, the stomium, the position of the lips, and the lip ceiling and everything. So we have here in this patient, for example, very beautiful profile, very beautiful facial type, mesiofacial type, and expected to have a little bit more of lower anterior face height in relation to the middle and the upper face height. Okay? And when we go, we're gonna see this to the thirds, the lower thirds. We see that she could have a little bit more of lower lip length from the lower stomium to the menton. It would be acceptable in her case because of the upper lip thickness, upper lip length, I'm sorry. So let's move on. We have it here, and we see in this patient that's a little bit too much, but she wasn't really concerned about it. She didn't know it. She didn't even know that she had this lower anterior face height increased. So for me, it was okay since she had a good balance, facial balance. And here we see, we can do that by means of using the points of the keynote or the PowerPoint, because again, we are dealing with the ratio, the relationship between thirds, not the absolute numbers in millimeters, okay? So we can use this. It's very easy to do. If you have a facial template for that, you're gonna see those dots, those points that are gonna be considered. The class 3, it usually breaks this balance of the face. It's very common to see this very heavy face, let's say, with the lower anterior face height predominant in relation to the other thirds, and the lower 2/3 of the lower third, meaning from the lower stomium to the menton, they are asymmetric in relation to the first third. In this kind of profile, in this kind of class 3, we usually have this, okay? And this is something that very, very commonly drives class 3 women to surgery. They come looking for surgery because they don't like this heavy profile, this heavy facial aspect, like being rude. I would say like something like that. And we have the opposite when we have the real mandibular deficiency. So in this case, we have the lower anterior face height decreased because we don't have enough displacement of the mandible down and forward, with the growth being back and upwards. So we have a lower anterior face height decreased, usually decreased. Let's see like this. But look at this. If we go like measuring this number, we go like the millimeters when we use this analysis here, for example, of McNamara, it's gonna be all the time increased. Why is that? Because of the displacement of the dots, of the points that we are considering our references. So we go to the anterior nasal spine and we go to the pogonium, to the menton, I'm sorry. So this height, this distance here is gonna be increased because of the displacement of the mandible in relation to the maxilla. In this case here, we have a lower facial, no, let's say, a cephalometric lower anterior face height increased, but a lower volume of the face. Why is that? Because the volume is very, very empty in this kind of patient, but the number is gonna be increased because of the displacement of the points that we consider the indications to do this measurement. Okay, so we see here before treatment, and just look at the volume of her face before and after. So you may have a decreased lower anterior face height now in relation to before, but the volume is completely different. Again, we need to add more and more information so we can be sure that we are doing. Never pay attention just in one aspect, in one only measurement for doing your evaluation, your assessment, or some specific point, some specific feature of the face. Okay, so we have it here before and after, seeing that even though we probably have now a lower anterior face height decreased in relation to before, in this photograph here, we have a very decreased volume here in relation to after surgery. Okay, and now we go to the profile analysis, and we go a little bit quicker here, faster here, because you all know everything about it. I'm just focusing on the relationship between what we see and the treatment planning. Facial profile, we see the facial profile based on three points. We go to the glabella, subnasal, and the soft pogonium, and we see the angulation that we have. We can consider a class 1, a class 2, or a class 3 in relation to the angle which is generated here. And this angle is very, very, it's not precise, I would say not precise, but it gives us the information that sometimes we want to pass to our patient, you know, to say to our patient. And here we have what we consider a class 2, 159 degrees, and for being a class 3, we don't even have to be more than 180 degrees. With, like here, 177, we already see this heavy face, this very rude profile, this very strong chin, very strong mandible. And here we consider that, we put in our chart what we consider class 1, class 2, or class 3, and here are the profiles. But for that, remember, we sometimes have a functional displacement of the mandible, which is very common in class 2 and class 3 cases. In class 3 cases, because of the contact between upper and lower teeth, lower incisors, and the mandible sometimes, because of this unstable positioning of the contact, we go forward with the mandible, and we have this jump of the mandible, changing the profile. And in a class 2, it's quite the opposite. We have people seeing and understanding that they have more pleasant faces when they go forward with the mandible. People see that in the mirror. Without even knowing that, we naturally see that when we have a stronger chin, stronger or mandible in relation to a class 2, we have a more balanced or more pleasant face. So we change it all the time. Understand, we need to do our treatment planning, our diagnosis based on true analysis, not false positioning, of the mandible. In this case here, as you can see, this lady here is presenting this class 3 condition, 187 degrees of what makes her a concave face, gives her a concave face. And when we go manipulating the position of her mandible to a central occlusion, we see that we are going to change the position of the mandible itself. So now we have a less concave face, 176 degrees, which is, yes, a class 3, but completely different from before. This is a very acceptable face, different from the face that we saw before. So we see here that this is a condition related to the displacement of the mandible in a functional mandibular closure. So it goes forward with her mandible. Not a very good, precise way to do this evaluation. Here we have it. Again, we have a proclination of her mandible, and when we put her in a central occlusion position, we see that we have a very interesting difference. In this case, I would treat her like this. I would have treated her like this. Unfortunately, this lady didn't want to treat because she didn't have time for that. She traveled to another city. I would be very pleased to treat cases like this. But I would treat this way, increasing or regaining her lower anterior face height. So this is very easy to treat. Very different from this situation. If this was true, this would be very different. But in this case, the right position that we need to focus, to put in our minds to establish our treatment planning is based on this condition here, on this position here, okay? So we have many possibilities in our face. Why is it important to understand what we have as a malocclusion? Because all the malocclusion, let's say a class 2, the most common malocclusion that we are going to treat. What do we have in a class 2 condition? We can have either teeth going forward, we have the teeth plus the bone. We sometimes don't have upper teeth, we have the lower teeth going backwards. For example, when we lose prematurely the first lower molar, and we have the occlusion in a class 2 condition, so completely different treatment planning for that. But we also have class 2 because of mandibular deficiency plus a dental condition. So we are changing the topics, we are changing the points that we are considering right or wrong, and changing those points, we are changing our treatment planning also together. And this is very important because we need to understand what we're going to do. Sometimes we see people, mainly in the social media, saying, I want to do this by means of TEDs. But is it really indicated to do TED in that specific situation? Can I see the face? Is the face really, really a good face, and you're just wanting to do this distalization of the upper teeth with TEDs? What's going to happen with her or his face when we do that? So we need to focus on what is the most important thing. Patient's facial, smile analysis, occlusal analysis, and put everything together. And in the end, we use cephalometric analysis for that. I'm not a huge fan of cephalometric analysis because everything that I see in cephalometric analysis must confirm what I see before. If I don't see the confirmation, I rely on the facial analysis. Point. Plain and simple. Let's move on. So sometimes you don't have a real class 2. Sometimes you have a maxillary vertical access, which displaces the mandible back and downwards, which is different from the treatment planning here is completely different also, because we can do the impaction of maxilla. We don't even need to put one appliance on the mandible sometimes, and we can do the correction of this just by means of intruding the maxilla. Impaction of the maxilla by means of surgery or TEDs, or if the patient is in a growing phase, we can use splits, like splints for that, or thorough splint is a good option sometimes. Okay, so we see here another condition, and we go more and more increasing and increasing problems in this face. So when we go increasing and increasing those problems, we're getting closer to a more invasive treatment planning like surgery in cases in which we can't change much without jeopardizing good features of the face. This is very important also. So we see here the profile. This is Nina with her profile 165 degrees, which puts her in a class 2 condition. Okay, so we have it here, a class 2. And since, again, we see everything together, since I considered that her maxilla in a good positioning, starting from the face, now I'm trying to find the best numbers in cephalometric X-ray, like McNamara triangle, which is a subjective analysis for that. I try to find the best ratio for the mandible related to the maxilla of 88 millimeters. It would be 111 to 114. And as you can see, she has not that much of mandible and a decreased lower anterior face height. So I'm considering Nina a good patient to treat with mandibular advancement. Because as I told you before, I know that when I do this in this profile with lower anterior face height decreased and everything, when I go forward with the mandible, I increase the facial volume, which is very good for, especially for women, growing women. We are now regaining, we are now having again what the nature should have given us before, like a good volume of the lower third. And here we have it. So that's based on all those analyses, plus the cephalometric X-ray, plus everything that I told you before, we established a treatment plan. Completely different from this case here. As you can see, we have a concave or a convex profile, 167 degrees. But in this case here, I don't have a receded chin, I don't have a deficient mandible, I have a vertical displacement of the maxilla, and the mandible went down and backwards. Now the treatment is completely different. We go up and forward with the maxilla and expect with that the auto rotation of the mandible going forward and upwards, which in this case will favor tremendously her face, will favor very much her face. Okay, so just for you to see that not numbers, not just numbers, not just angles, we have everything together. We need to put everything together. So you see here that although she has this convex face, she has a good relationship between maxilla and mandible. Let's move to the numbers of the table, of the chart. We see 91. Let's say we have a good maxilla. We don't, but let's say we do. And in this case, we would expect like 123 millimeters of mandible here in this chart, McNamara's chart. But we have, I'm sorry, the McNamara's chart here, 115 to 118, and actually we have much more than that. But what is wrong here? Why don't we have a class 3 in this condition? Since we have a mandible that is not balanced with the maxilla, is larger than it would be to be compatible with the maxilla. Why isn't it forward? Because it rotated back and downwards. Look at this. The lower anterior face height here is increased. So we have now a completely different feature with completely different treatment planning, even though we have numbers that are close one to each other. We don't just focus on that, okay? So let's move on. I'm not gonna do everything here as I told you before. I'm gonna pinpoint here the most important things for you to understand why we focus on this to establish the treatment planning. And from there, we are gonna see in the sequence of webinars, in the sequence in our course, you're gonna see different things. You're gonna see this attached to the smile analysis, attached to the occlusal analysis, and why do we do this kind of bend, this kind of loop, that kind of torque. You are going to see that everything is together. Okay, so for that, I'm going to focus important things here that we use mainly because we want to do the correction, the sagittal correction, and we are in need to understand and to establish what the problems are. Let's move to the eyeball and the zygomag. They are equivalent in growth. So when we have a protruded maxilla, we have the position of the zygoma, the malar, the zygoma, forward in relation to what was expected. And we have some facial features to see that. The orbital rim is one of those. The orbital rim is an anteroposterior indicator of maxillary position. Deficient orbital rims may correlate positionally with a retruded maxillary position because the osseous structures, remember the equivalents, are often deficient as groups rather than in isolation. The globe normally is positioned 2 to 4 millimeters anterior to the orbital rim. So sometimes we don't even need to, because it's very difficult to draw the precise position of the orbital rim. Yeah, it's not easy, but we see here that when we do this, and this is the way we analyze, we assess the position of the orbital rim, we go with the horizontal pattern, horizontal structure. Now we're using this plane here. This is similar to the Frankfurt horizontal plane. This from the perpendicular from this line, we are going to pass contacting the globe, and the orbital rim here should be in a position forward in relation to this. Some articles say 4 millimeters, some articles say more than that, but what I mostly see in this kind of situation here, using this horizontal reference, is that I see that we don't have volume in this area. I have this flatness in this area. This flat area here that we see, I consider a very bad position, sagittal position of the maxilla. And as you can see, another thing that is very correlated to this is the tip of the nose. It goes together with the deficiency in this position. So we know that in this kind of situation, we have this position of the maxilla retruded in relation to what was expected, okay? Cheekbone contour, another thing that is important. The cheekbone contour is used as one of the main indicators of maxillary retrusion. This area should have an apex at the cheekbone point, as you can see here, it is the cheekbone point, okay? And not appear flat. The cheekbone point is located 20 to 25 millimeters inferior and 5 to 10 millimeters anterior to the outer canthus. This is the outer canthus of the eye, okay? As you can see here, it is positioned distal to it, not anterior to it. It's posterior to it, meaning we have something that is related to deficiency in the maxillary bone, okay? Sagittal deficiency. When viewed frontally, the cheekbone point is 20 to 25 millimeters inferior and 5 to 10 millimeters lateral to the outer canthus, like this, okay? Again, not easy to see, not easy to understand, but we can see that with time, this is something that can jeopardize patients' profile and also the feeling of the face. As you can see here, we have this deficiency, and with time, we see this soft tissue here without good grip, good volume, okay? And this is something that, of course, we need to tell our patient. And when we plan for this kind of treatment, sometimes we need to plan for doing fillers, like hard fillers for this, because when we go forward with the maxilla itself, the bone, it goes below the position of this area of the cheekbone. So if we want to favor this area also together with the maxilla going forward, we need to use fillers for that. And then we need to tell that our patients. So sometimes they think it comes in a package. Everything goes very, very well and go with an orthognathic surgery going forward with the maxilla, but it's not always like this way, okay? So sometimes we go forward and we have a good position of the maxilla, but this flatness, it remains. So we need to tell that to our patients. Here it is, this area, which is not easy to see and to understand. And now I want to call your attention to another aspect. So if we know that our patient, in this case here, our patient has this maxillary deficiency, we know that the lips and the bone are different from the right position. So in this case here, what happens is, if I want to do the compensation of the treatment, I want to do the compensatory treatment, what's going on here? I need to go outside of the bone because the bone is not growing when I do this kind of positioning of upper or lower teeth. It remains in its position, but we do the compensation, and when we do that, we go with the teeth through the bone, not with the bone, through the bone. So when we do that, sometimes we have this outcome here. So you know that, you understood that, but if you don't tell that to your patient, even though you may have a very beautiful treatment, everything perfect, class 1, good inclination, not a good inclination because it's going to be compensated, but we are gonna give our patient a different aspect of the smile. Why is that? Because the inclination of posterior teeth are gonna be different from what sometimes they expect. And we know that. So the effect of buccolingual inclination of maxillary canine premolars on perceived smile and attractiveness. If you go here, you're gonna see that most people, lay persons and also orthodontists, prefer zero inclination of posterior, a little bit positive, but not that much positive, but especially a little bit negative. When we do this in our patient, because we know that we need to do this compensatory treatment, knowing that the maxillary deficient is a problem of that patient, when we do this with our patient knowing that's going to be the outcome, it's okay. But when we do that without telling our patient that this is going to probably be the outcome, this is going to be for you a headache. Your patients are going to ask you, why do I have this extremely inclined teeth, both anterior and posterior? I think there's something wrong, something off here. So before doing that, you need to tell your patient what's going on, okay? Here it is. We have here the inclinations. The class 1 inclination is expected when we have a very balanced face with class 1 with good maxillary size and mandibular compatible sizes, okay? In this condition, it's okay, but we need to adapt. And when we adapt, sometimes in the smile, it's not beautiful. And patient, they feel that. So before doing this, talk to your patient. You know why it's important, facial analysis? Because if you put everything together and you put everything in a visual presentation to give to your patient, they will understand everything and they'll accept or not, but based on a visual thing that you gave him or her. And then they can decide, I want that, no, I don't want that. So if you don't want this inclination of posterior teeth, having this deficiency in maxilla, you need to undergo orthognathic surgery, because this is the only way that I can give you the size of the maxilla, both anterior and posterior. Nowadays, you have the possibility of doing that by means of MARP, but this is also some kind of surgery. So you need to talk to your patient before doing that, okay? Let's move on, and here we have her smile, and sometimes it's not a good smile. And again, lateral view, same thing. If we are dealing with a class 3 patient with maxillary deficiency, we need to compensate. We are not treating a class 1 patient. So in this case, I need to go with the inclination, increasing the upper teeth inclination and decreasing the lower teeth inclination. Both sometimes may be seen by your patient as something off, as something not very beautiful. Okay, so we have it here. This is the inclination expected in a class 3 situation with a compensatory treatment. Is it okay? Well, the treatment is okay, but sometimes for your patient is not that okay. Okay, so we need to talk to our patient that if you want this inclination here, I need to fix your bone position. Otherwise, I need to remain with that inclination that you don't like. Understand that. Facial analysis. You are going to think forward. You are doing everything up front. You're giving your patient all the options so they can decide. And based on real good information, okay? Real good information. Let's move on. Nasolabial angle, another feature that I consider very important, especially because it's related to the distalization of upper arch, the retraction of upper arch, and is completely related to the inclination of upper incisors. Let's move on, and I'm going to show it to you. What's the best nasolabial angle that we consider nowadays? The nasolabial angle is the angle formed by the intersection of the upper lip anterior and columella at subnasalis. So we have this is where it crosses, and we see the angle here. What's the best angle? Nowadays, we see that people want full profiles, full lips. So sometimes we have a lip that's not compatible with that kind of smile. And this is something that I always say here. You need to focus on diagnosis. We have nowadays this trend to do the harmonization or facial harmonization, in which people give fillers and fillers to the lips, and the hyaluronic acid is everywhere, but sometimes it's not compatible with the position of the upper lip, of the upper incisors. Sometimes you hide the upper incisors during the smile, during the talking, and this is very bad. It gives age to our patient. So it's not, for that case, it's not indicated. If you go to the facial analysis and understand everything, you can give your patient more options. You can say, no, my patient don't want to do this, but I understood the problem, I gave him the options, and he or she understood the problem, and now she or he, they want to go this way. If I think that I'm gonna favor my patient in some way, I can go with the treatment plan. But if I can jeopardize patient profile and give him or her age very early in their lives because I'm hiding teeth, I don't go this way, okay? So this is everything based on facial analysis. Here we have it. We have two different angles. I would say that most of you, or probably all of you, will prefer the more acute angle than the more obtuse angle because it resembles youthness, and we know that. Some authors have observed a change of up to 10.5 degrees in the nasolabial angle for retractions greater than 3 millimeters. You know, retraction, class 2. Some people say, I don't do retraction because I don't do extraction, but you're treating class 2. If you're treating class 2 in the maxilla, you retract. Point. If you're doing the retraction and not controlling the inclination of upper incisors, you are gonna have a worse outcome. But sometimes we do the retraction, but we control the inclination. Controlling the inclination, we don't even see a change, a negative change in the nasolabial angle, because it has much more to do with the inclination, okay? Sometimes we lose a lot of inclination and we see the disaster that we give to that kind of nasolabial angle, okay? And we have others and others topics saying that. But again, if we control everything during our treatment, let's say this case from Carol, one patient of mine, she underwent 4 bicuspid extractions, and we did a little bit of retraction, but with good inclination of upper anterior teeth. And let's see what happens with time. And now we see that 15 years after treatment, we have a good positioning of upper lip, a good feeling of buccal corridors and everything, even though we did extraction. Again, it's more related to the control that you give to your treatment. But remember, if you have too much of retraction to do in the upper arch because you have a huge overjet, it's impossible to control that. You are gonna lose lip protrusion. That's point. Nothing can change that. Of course, you can do a worse treatment when you lose inclination, but you are gonna lose. Again, if it's possible to do that without worsening too much patient profile, you can talk to your patient. But I, myself, nowadays, I always say, I won't do this because I know that with time, you are going to point your finger to me and say, you did it to me. So I don't like this kind of outcome, okay? So again, take care. This is very, very important. This is our patient. This is one colleague of ours. I did this simulation of the upper position of the lip, the nasolabial angle, and we did it here, an article based on this. We wanted to know what nowadays here in Brazil, what is the most pleasant nasolabial angle to people. And we see that people tend to prefer a protrusive lip, but not that protrusive. When we have an extreme protrusion of upper lip, we have the sensation of that something is in excess, and we don't like it also. We don't like it. But when we change this, hiding the lower part of the face, sometimes people accept a little bit more of proclination of upper lip. But again, if we just look at one topic, one aspect, one specific feature of our face, we are hiding some points that are important for our treatments. In this case, for example, if we just focus on the nasolabial angle, you're probably thinking that this profile is good, or this profile is good also, because we have protrusive lips. But when we sit together with the lower part of the face, sometimes we don't like it. Again, we need to see everything together. That's the main point here. So I know that most of you won't like the 80 degrees. And here we have something close to that. We have a very acute nasolabial angle. And when we want to do this, to change this angle, we can do that by means of retraction. And during the retraction, we can choose, especially nowadays, because we have the TEDs for that, we can choose by means of having the extraction made, or doing the distalization, the Bimax distalization with TEDs. Okay, but I consider that very difficult sometimes. We don't have enough space distal to the second upper molar or second lower molar in the ramus of the mandible. So sometimes, I would say most of the time, in this kind of situation, I prefer to use the distalization of the upper and lower arch with extractions, okay? Using extractions for that. Here we have it, the extraction of upper and lower first bicusps, and after doing the retraction with a little bit of anchorage loss. I'm not gonna talk much about it, but one point is important here. People would say, you need to use TED when you have the Bimax protrusion. It's not true. It's not true. We don't have enough space to do the retraction without putting the root outside of the bone in the lower arch most of the time. So if you don't have it, you want to go like 4 millimeters, 5 millimeters, but you need to lose a little bit of anchorage. That's an important point for you to keep in mind. Let's move on. Here we have it. Okay, before and after, and we have more. And here the outcome to the face. So look at this beautiful outcome for her upper lip. And the lip sealing, the passive lip sealing, which was something that her mother always pointed out. She now has a beautiful lip sealing. She doesn't have anymore that kind of protrusion, and this is something that our patient like. Okay, and here we have it, like this this retraction that we did, that we made before, and we have before and after treatment, and after retraction, I'm sorry, and then you see that we have a good change in the upper and lower lips. So for you to see that we can change in the direction that we want. What if we want the opposite? What if we want to do the proclination of upper and lower teeth to favor patient's profile. It's completely possible. Here is just for you to see what I do most of the time to see this. What if we want to do the proclination of upper and lower teeth? Is it going to have a good outcome to the upper and lower lip protrusion? Yes, it's going to go this way. Look at this here. We have before treatment in class 2 division 2, and after doing the proclination of upper and lower teeth, using for that torques, look at this, using for that torques, and making the space for having the veneers, because she has this tooth size discrepancy, and we did that by means of veneers plus torque. And what we see in her upper and lower lip after that, look at this. Look at this. Beautiful, huh? And here we are with the outcome of the torque in relation to the upper and lower lips. Consider that pretty much important. So guys, that's what I wanted to talk to you before we move to our second part of our course. We have other topics that we are going to add in our next classes. Why is that? Because for now, for you to understand the torque, the relationship between the retraction, we are going to show cases like this, and the importance of understanding everything that we put together here when we go to the next step, the treatment planning. And the treatment planning, establishing the treatment planning, we're going to focus on the details of the mechanics to refine our orthodontic treatment. Believe me, everything is tied together. Everything is like gated. We're going to go from here to the refinement of the occlusion using all this information that I gave you today. And we're going to add more information. Okay? So very good to talk to you. Hope you are sound and safe, and see you soon. Bye-bye.